to seek your feedback after the talks, if that's okay. So we're doing it with Mentimeter, and Anna will talk you through the process, but it's a very quick process that you do there and then at the end of the talk. So please, if you could do that, it would be useful to get your feedback. While we're waiting for a few latecomers, I'll just do a general introduction. The first talk having today is around access to services in rural areas, which is a topic that has been discussed ever since I've been involved with health services over many years. And I remember talking to Chris Martin, who was the then chairman of Hywel Dda, over 20 years ago, saying, they've got these mobile cardiac monitoring labs in India. Could we not do that in this part of Mid Wales? And 20 odd years later, I'm very happy to say we're having a presentation on one of those very things. So I really look forward to hearing what Hannah and Liana have got to say. I also remember many years ago speaking to Mr. Holt about the breast cancer services in West Wales, which at the time was considered one of the leading services nationally. And I asked him, I said, so how have you managed to get this? And he said, well, the main reason we've got such a good service with the screening and everything is because we finally got a lady prime minister, and that was back in the time of Maggie Thatcher. So my feelings from those two conversations is we need frontline staff who are prepared to grab the moment and actually put services into practice for a rural population. And we rely on those frontline staff grabbing the moment. So my message to all frontline staff is please grab the moment if you see it can make your idea come to fruition. Although, you know, as we know, things take a bit of a while to come to fruition within the NHS. So I'm very cheered by the two talks we've got today. So I will now go on to the housekeeping business, because I think everybody's joined. So the first thing is that if everybody could keep their microphones off, unless they are asking a question or presenting, obviously. Whether you have your camera on or off, I think is up to you. It seems to work fine with cameras on, but certainly for me, sometimes I have to turn my camera off so that my broadband is capable of letting me hear and see what's going on. So it would be great to see you if we can, but we understand if you can't. And please understand if I have to turn my camera off as well. I will attempt to always have it on while I'm speaking. The agenda for the day you'll have seen. So we've got 30-minute presentations followed by 10 to 15 minutes for questions and answers after the presentation. And please, if you have a question, either raise your hand and hopefully I'll see it. I'm sure Anna will prod me if I don't. Or please put any comments or questions in the dialogue box and we'll attempt to answer them if we have time. We are, unfortunately, because we're on Teams, unable to have simultaneous translation. It's the problem we have with Teams, so we're very much apologise for this. But if you want to ask questions in Welsh, we'll do our best to accommodate that, and members of the team are able to translate your question for you. We're also recording this webinar session, so that everyone who's registered to attend will be able to access and download it via the chat feature after the event. So please, if anybody has any objections, could you make that known to Anna now? Otherwise, we'll assume that everybody doesn't mind this is being recorded. So let us hope that the technical gods allow us to have this morning without too many interruptions. And I think think it's at this point that I probably hand over to Hannah Jones and Liana Shearley, who are both advanced clinical physiologists with Betsy Cadwallader up north. I believe they're talking to us from the beautiful island of Anglesey. And they're going to do, as I said, a presentation about mobile diagnostic vehicle for rural populations. They have recorded their presentation, but they are both with us to answer questions at the end of their presentation. So can I hand over to whoever's the technical wizard now to start the presentation? Thanks, Anna.
Yeah, I'm the technical wizard. My magic's going to work. So I'll share it now. Oh, hang on. Sorry. Try again. It's just taking a minute to prepare because there's sound on it. Can people hear that?
Right. We've got a circle going round and round at the moment. Ah, that looks better. I think you've jumped to slide 3, Anna.
Okay, we'll start again. Sorry about that.
There's no sound at the moment here.
I'll check that it's his sound.
I've sent you through a British Heart thing, or British, whatever it is.
Great, thanks, Liana and Hannah. I was having trouble with my sound, and the moment I finally got sound, the first sentence I heard was "hot and sweaty mess in plastic." I did wonder if I was being Zoom bombed or something. But thank you for that, and that looked a really brilliant innovation. So we'll now, if you could turn your cameras on, Hannah and Liana, so we can see you, we'll get some questions from the floor. So if anybody has a question, please raise their hand. In the meantime, I will ask a question while people think of any, which is, I believe you said you were set up originally with charitable funds. Are you now getting core funding from the Health Board, or is it still based on charitable funds?
No, what originally happened was the cardiology charitable funds fronted the cost, and so the van is actually paid for by Betsy Cadwallader, but Arrow Last are running an ongoing charitable campaign to reimburse the cardiology charitable funds. So they're still sort of ploughing away and reimbursing the other charitable funds, if that makes sense.
Right. So yeah. So you are funded by the Health Board, but the charities are raising money to contribute to the capital cost of starting it.
Yes. Yeah, there is actually the capital cost. The running costs have already been accounted for in an ongoing business case, which is a yearly thing. So that's already been accounted for.
Great, thank you for that, because quite often these innovative things tend to need charitable funds to get off the floor. So yeah, my interest is always that they should be core funded.
Yeah.
Great. We have a question from Karen from Haldar.
Hi, really good presentation. Really enjoyed that. Thank you. Just wondering, did you take that echo machine out of service from another site? That was my first question. And secondly, how many did you anticipate doing, or do you do in a session, like in the morning or an afternoon?
Okay, so the echo machine, and because we work in the community, each one of us has our own echo machine that we take to the community hospitals. So it would, whoever would be in that particular van would use their own echo machine. So we would use the one that was designated for us. In terms of how many people we saw in the day, because it's a one-stop clinic, it's a heart failure assessment, not just an echo, consisting of a history examination with the echo, diagnosis, management plan. We usually don't see any more than about 4 people in the day, 4 to 5 people at a push.
Okay, thanks. Great.
Thanks for that, Karen. There's a question or two in the box, so we'll take one of them first. I'll come to you, Tom, in a minute. Which was that apparently there was a decree or diktat or something from the Health Board that said not to visit people's homes to do tests due to COVID. Have you had any issues with your staff on that basis?
Yeah. No, we actually liaised with infection prevention, who went through what infection prevention PPE we would need, and we actually had sort of training in donning and doffing. So we liaised with the appropriate people at the time, and they were quite happy. And during our home visits, none of our patients and none of the staff contracted COVID.
Excellent. Tom, I'll come to you in a minute, but Kate, you've had your hand. Katie, you've had your hand up for a while.
Hi there. Just a really quick question. Thank you so much for that. It's brilliant. I actually don't work in cardiology. I work in prosthetics, so artificial limbs, and it's something that we've been considering for a little while, just because we only have one centre for the whole of North Wales. I was just curious if you're able to either share now or if I can get in contact later about who the company were that you used. We've looked at the lease company Knowles, Knowles Fleet Stuff, and also just practically whether or not you've got any sort of links with, you know, any of the car parks that have got electric charge points, if there's any way that you kind of can cleverly connect in instead of using your generator.
Yeah, no, I can definitely give you, the company that we used was Taunton Bodies, and they've actually been used by BCU before.
That's good.
So they were already on the framework, so that made life a little bit easier. In terms of, and we did all the ringing around, we sort of looked at converting an ambulance, looked at buying a vehicle, and actually this seemed the best option from that point of view. In terms of electricity, we've got a 20-metre cable, so if we park up close to a window, we can literally just put it in through a window and have a connection to a plug on the inside. So that works quite well, but obviously we've got a generator if we haven't got that access.
Brilliant. Thank you. Thanks. That's brilliant.
Great. Thanks for that. Tom?
Well, can I first of all say congratulations to you? I mean, it's really excellent. You've had that initiative, and hopefully it'll be the start of a lot more as far as North Wales is concerned. I used to work in the States, and 20 years ago in rural America, we had vans of this nature going around. And I recall, apart from cardiology, we had ophthalmology and also oncology vans going around. So I'm hoping that some of your colleagues are also paying attention to your success, and we'll be having more of those later. I just wanted to make one comment of differences. In the USA, there was an endeavour to have patients in the community hospitals who were rather sicker than we tend to have here, where we tend to be used our community hospitals more for rehabilitation. And every community hospital had a docking bay. And so the vans like yours could reverse into the docking bay and could deliver the system as if they were part of the hospital per se. And I wondered whether people in estates in Wales were looking at you and thinking, well, with developments such as Welshpool coming along, isn't it time we started putting a docking bay there and getting into the space age instead of sort of still being back in the last century?
Good point.
Do you wish to comment there, Hannah Liana?
I think the future, we found that this innovation's been so successful. I think, any steps forward are possible. I think we should be thinking really outside box now, particularly post-COVID. So no, I agree with Tom. I think anything's possible.
Great. There's a couple more questions in the box because I can't see any hands at the moment. I think you partially answered one of these already. Did you have your clinical equipment apart because you had 70,000 to buy the van? Did you have the equipment already, or was that on top?
No, the clinical equipment we already had. So the 70,000 was just for the bespoke van.
Yeah, fine. There's another question from Claire. Do you need permission to park in car parks?
Well, if it's BCU owned community hospital car parks, we've just liaised with the hospital administrator because they'll also cone off an area for us. So if they know that we've come in, they'll cone off an area the night before. If it's GP practice car parks, then we've liaised with the practice managers. We haven't at the moment parked it in somewhere like Tesco's. So, but, I suppose as long as you seek the appropriate permissions.
Do you foresee you will be doing it at places like?
I think probably community hospitals or GP car parks are probably accessible for most people.
Yeah. So because the obviously some of the mobile screening is done in supermarket car parks, but do you need other services nearby in case, or would it be safe to do it in supermarket car parks?
Yeah, I mean, it would be safe. We have an onboard defibrillator as well, so we've got resuscitation equipment on board. So should we have any problems? but I suppose for ease and making sure that we've got spaces available, and you know, at the moment we've just used the community hospital car parks and GP car parks, but it's certainly not something that is out of the question. You know, we're only just developing it, really. We only picked it up in September. So.
It's just, I mean, I'm sorry I couldn't hear all your presentations, so you might have answered this, but do you do drop-in, or are they all appointments?
They're all appointments.
So do you envisage a drop-in service ever?
No, these patients, the patients that we see are patients that have been referred to us via their GP with suspected heart failure.
Right, right.
And for us to keep, because at the moment our waiting times are very short to ensure that we see these patients and get them diagnosed and treated. So we have to be quite strict with the criteria that we're asking from the GP. Right,
yeah, fine. Pat, you have your hand up to ask a question.
You're on mute, Pat, I think.
Hi, Pat, are you having any joy? If you're not having any joy, do you want to type it into the chat box and we'll ask the question for you? There's another question in the chat box. What was the blue van on your slide? It looked like a trailer of some sorts.
Yes, that's when we did the initiative with the community arrhythmia nurse. She asked us whether we would do a one-off looking at patients, pulse checks on patients that were going to be vaccinated, and that's a Keep the Beats trailer. So that's a trailer that needs to be towed, and that's part of the arrhythmia service. So there was two sort of vehicles.
I presume that's Pat on, because we've got terrible feedback. Pat, do you wish to ask your question?
I find a way around now.
I think, Pat, you're causing terrible feedback. Do you mind typing your question in the chat box? We can't hear you, Pat. I'm sorry. So if you type your question in, I'll ask it on your behalf. Not nearly as nicely as you would, but I will ask it, obviously. There was another question, which is just a technical one. And I think, if you don't mind, we'll be sharing your details with everybody afterwards, so they can actually, via Anna, get in contact with you, if that's okay. But there was a question about the company you bought the vehicle from.
Yes, that's. I think I sort of said that earlier. It was Taunton Bodies, and they're in Telford.
Yeah, yeah.
And they were already on the framework and already built already built a few things for our trust anyway. So.
Yeah, and do they work with the NHS across Wales? Do you know?
I think so, yes, because certainly when we went down to visit, there were other vehicles being built for other trusts and health boards. So I think they do quite a lot of this sort of thing.
Seems to be across the UK. Yeah.
Yeah, fine. So they're the go-to, really, are they?
Yeah.
So Pat's question, which has come through now, what is your training for this, and do you do follow-ups?
Okay, so do you mean for the actual clinics themselves? What training we've got? Okay, so
Pat's asking if there was extra training to be able to do it in the van rather than as you were standardly doing it. If you see
okay, no, there's no extra training for the van. Yeah, no extra training to be doing them in the van.
Yeah, and do you do follow-ups? Is the next question.
Well, our clinic is a diagnostic service, so once we've made the diagnosis of heart failure, they're then followed up in the community heart failure team, or they're discharged back to the GP.
Fine. I misunderstood Pat's question. She's a doctor herself, and she just wondered what your basic training was.
Okay, so my basic training is I'm a physiologist by trade. and I've been in sort of cardiology for 30 years. I've then gone on and done a master's in advanced clinical practice. I've then also done a practitioner. I'm also accredited with the British Society of Echo to do scans, and I'm a BSc examiner as well for the British Society. I've also done a postgraduate practitioner course for practitioners with a specialist interest in cardiology. So the same course that the GPs do for the GIPSY course. So I've also done that as well.
Great, thank you.
Does that answer your question, Pat?
I think by the smile on her face, yeah.
Okay.
So Karen has got her hand up. Karen?
Yes, just one thing. I mean, I'm so impressed with what you've done. Thank heavens for your husband.
I know. I have to credit him every time.
Well done. I'm just wondering, I mean, having worked in the NHS, it just seems that it happened incredibly quickly. I'm well impressed, because having worked with clusters, things take forever. So that's I don't know whether there's any hints you can give about how it did happen so quickly, and also, is it used daily?
It's not used daily at the moment. We probably use it a few days a week, because at the moment we're sort of still finding, we've only picked it up in September, so we're still sort of, there's other services that have shown an interest in wanting to use it as well. So we are using it quite a lot, but we obviously need to increase that. So yeah, so in terms of that, we sort of need to, how quickly it went through, I would say, just you need to hassle people. I was constantly sort of like hassling people and saying, "Well, have you seen this email? Can you sign this?" And I think I sort of had a bit of a reputation similar to the Go Compare man, and I think they were a bit worried that I was just going to turn up when they got out the shower and go, "Sign this," So I think it's just persistence, and it was incredibly quick, but yeah, I think the overall idea was a real no-brainer. Particularly, we're in this COVID pandemic where patients are worried about going to hospital. We need extra room. A mobile clinic room just ticks all the boxes. So
I think probably in this instance, COVID helped, didn't it?
Absolutely. Yeah, I think so. Definitely. Yeah,
absolutely. And I'm well impressed that you're willing to share it as well.
Oh, yeah.
Thank you very much.
You're welcome.
Thanks for that. Claire has put a question in a box, which is you've pretty much covered with that last one, which is, are you planning on extending your service? I mean, is the van got capacity to do a lot more, or if you extend the service, do you need another van?
I think there's always the potential to have a fleet across North Wales. I think that'd be awesome.
Yeah.
But yes, I think now we're looking at that there's such a reduction in clinic rooms, and there's such a waiting list of diagnostic services. I think having the van it's so useful and so versatile.
We've seen a massive benefit. From January is a really busy month for us. Just be able to take the van, so we've been doubling up. So one of us has been in the van, one of us in clinic with other colleagues as well. So it just means that we've been able to see patients just as quickly through one of our busiest months. So yeah, it's just been fantastic.
Yeah, I think you're preaching to a converted audience here, and for those of us who live in the more rural parts of the tendency now for diagnostic centres to get through the backlog is great, but they tend to not be very near any of us in rural areas. So this sort of innovation is great, and I think there would be merit in trying to do it across the whole of Mid Wales, which would involve the joint committee, the 3 health boards there, actually possibly working together to deliver the service across the 3 health boards. So watch this space, I think.
Definitely.
There's another question from Katie, which is, do you need one staff member or a driver and another in the van?
No, because the van is under 3.5 ton, anybody with a full driving license can drive it. So the clinician can drive it to wherever they're doing their clinics.
Great. And there's another question from Gareth, which is about wheelchair access. I think you did mention that in the presentation, but if
yeah, we have got ramps that attach to the back. It would probably be a little bit tricky getting patients with wheelchairs up on the ramps, but while we've got the community hospitals as well, I mean, we could do it, but if we've got the community hospitals that we're still doing clinics in, we would probably favour them going to the actual community hospital, which is a little bit more accessible for them.
Right, so it's feasible, but not as easy as it might be at the moment.
No, that's right.
Yeah, and then Roberta's got a question in there, which is leading on from my comments, which, have you been approached or had interest from other health boards about, well, she's put a very rude word, copying your...
Yes, we've had loads from other health boards in Wales and also other trusts in England as well, and different disciplines. So sort of audiology, sleep services. So lots of people have been in touch with us and asking for details and how we've gone about it. So yeah, it's been really quite exciting, really.
Yeah, well, I have to say, as someone who lives in a fairly rural part of the country, this sort of innovation is fantastic. And as I said at the beginning, I was muttering about it 20 years ago. So congratulations to you two.
Thank you
for pestering people enough to get it going.
Yeah.
So if you're happy, we will be sharing your, I noticed you put it on your presentation anyway, that we'll share your details and via Anna, if that's okay, if people have other questions.
Yep, that's fine, absolutely
Brilliant,
fine.
Brilliant, thank you very much. And I think in order that we don't overrun, I've got to say thank you very much to both of you now for your presentation. And I think Anna wishes to do something technical about feedback on it. So luckily I get to hand over in a moment. So just on behalf of everyone, thank you not only for your talk, but for this fantastic innovation that
thank you.
is a model for other things. If we can push it, that's great. Thank you both so much.
Thank you.
Anna, can I hand over to you for the Mentimeter bit?
You can. This is very quick, and it's a new, well, we tried it in the last webinar. It worked last time. We're hoping it's going to work this time. So I'm going to share a screen with everybody, but those of you who've got a phone or can access the internet, if you can go to Menti, MENTI.com. If I put the in the chat box now, I will do a quick online evaluation to see how useful you found the presentation. I'll bring a slide up and it will show you the questions that you'll be presented with. You then, once you got to, just finding it, when you've got to the website, there's a code to put in that will link to this. So if you get to menti.com, use the code. Can you see it at the top? 2695-6493. Can you see it? If you can type that into your phone, and then you'll get an option to drag to score these 3 presentations. So if you can score it from 0 to, well, there we go. As people are scoring them, then you can see the results are coming up. So how useful, how interesting you found the presentation, if you thought the topic was relevant to you in the work that you do, and if the findings from what's been presented to you, do you think that would positively influence your work? So the top score of 5, you can see we have really high scores at the moment, 4.8, 4.5, 4.6.
Is that live as it's happening, Anna?
It's live as it's happening, yeah. So these are the scores.
Excellent. I hope Hannah and Liana can see how well appreciated the presentation was.
That's fantastic.
Yeah, well done.
Yeah, well done. It's yeah. You
So
had an appreciative audience, I think it's fair to say, on every level.
I think what we'll do though, Jack, if you want, because we've got just over 5 minutes before the next presentation on screen, and I can leave this on screen if you like, and people can have a quick break and come back.
You've taken the words out of my mouth. I was going to suggest we have a quick 5-minute break to grab a cup of tea or whatever, and we'll rejoin at 11 o'clock. And you'll leave that up while that's happening, yeah, Anna?
Yeah.
Okay. See you all in 5 minutes. Hi, Anna. I see someone's put that they're looking forward to receiving a copy of the presentation. Are you doing that at the end in the chat box?
Yeah, the trouble with this presentation, because it's got audio on it, we'll be sending a link. So we'll be uploading it to the website and we'll send a link of the recording onto the presentations. But yeah.
So that'll be in the chat box at the end, yeah?
Not in the chat box, no, we'll put it on the website and we'll be sending everybody who's registered to attend a link to be able to access it.
So it'll be sent directly to them via email, will it?
Yeah.
Right. Good.
And I think Helen is here. I saw her earlier.
Good.
Hi, yes, I'm here, Anna.
Are you able to share your presentation, Helen, or did you?
Yeah. No problem. I can bring it up now.
Do you want to introduce Jack?
Has everybody appeared to be back on? You can't really tell, can you?
There's quite a few on. There's 33 people here.
So, morning, Helen.
Hi there.
Hi, thanks for doing this. So I did give a brief waffle at the very beginning of the webinar, so I won't take up any more of your time. I'll just introduce you. So, and then if you could take over, that would be great.
Yes.
So, welcome back, everyone. I hope you managed to grab a tea or something, or get someone to make one for you. That's what's happening here. So I'd like to introduce Helen Jessup from Public Health Wales, who's the screening engagement specialist, to talk about the NHS screening and with a particular emphasis on rural areas, I believe. So Helen, over to you, if I may.
Oh, thank you, John. So thank you for inviting me to attend this webinar this morning. So I've got, I think, about 30 minutes. So I've got a presentation that will just give you an overview of screening in Wales. And just then when we've got an opportunity to maybe think about some of the issues that might affect people living in rural communities, and then just talk about some of the work that the screening engagement team do, and maybe some opportunities where there may be opportunity to work together to help raise awareness of screening in the communities you support. So that's what I'm hopefully aiming to achieve. So in terms of the session, I'm just going to give you an overview of the programmes that we offer. I'm not going to go into the ins and outs of every single programme. Obviously, there's not enough time to do that within this session, but just hopefully give you that understanding of which screening programmes we have available in Wales, who's offered those tests, and then maybe thinking about some of those barriers that may affect the communities you support, and what we have available in terms of helping to raise awareness of screening. And also knowing where to get further information. So in terms of screening in Wales, so each UK country does set its own screening policy, and that's based on the recommendations of the UK National Screening Committee. So the National Screening Committee will look at evidence, research, trials, and they then inform those decisions that are made in terms of which screening programmes are implemented, which ages are offered, how often tests are made, how often tests are offered, and then that informs then how the UK countries then deliver those screening programmes. So in Wales, we have a Wales Screening Committee, which is the National Advisory Forum on Health Screening Programmes, and it's Public Health Wales is responsible then for the implementation, management and delivery of the NHS screening programmes in Wales. So what is screening? So in simple terms, really screening is looking for early signs of disease or condition in people who do not have symptoms. And I think just it's so important to get that message across, because screening is aiming at a population level to identify people who may be at risk of having an early condition. And finding that condition early will give you then, it will give people the best chance of early treatment, survival and a better health outcome. So so often, I mean, I've worked in communities for years, and people will often maybe not think screening applies to them if they don't have symptoms of disease. So it's, I think, just a really important point to get across, that you may feel well even if you have a sign or condition. Taking part in screening is choice, is down to individuals making a choice. So we want people to feel supported in that decision making. So it's about having the right information so people can make a decision that's right for them. And we always stress that no screening test is 100% accurate. So even if people have been for screening, have been offered a test and had a result that has come back and said no disease is found, it's always important, if somebody notices a change in their health, they make sure they report that change to their GP, because there is a risk that some conditions may be missed or something may develop in between a screening round. And that applies to people under screening age, over screening age. Any change in health should be reported to the GP without delay. So what tests do we have available in Wales? So we have different screening tests that are offered throughout the life course. So mothers during pregnancy are offered screening tests to check the health of their baby and their health. So antenatal screening. Once babies are born, new babies are born, they're offered tests to check for rare diseases and conditions. They have their hearing checked. And then from the age of 12, anyone who has a diabetes diagnosis is offered diabetic eye screening to check for the disease of diabetic retinopathy, which can affect eyesight. And then from the age of 25 all the way up to 64, cervical screening is offered to women and people with a cervix. Breast screening for breast cancer screening is offered to women aged 50 to 70. And then bowel screening for looking for early signs of bowel cancer is offered to men and women aged 58 to 74. And then we also have abdominal aortic aneurysm screening, which is offered just to men, and it's offered at the age of 65, and it's a one-off. So that test is different to other ones, as it's just a one-off screening test that's offered. So, as I said, I'm not going to go into the ins and outs of each of those programmes, because that would be a lot of information to cover in a short time. But what we'll talk about is almost like the screening journey that people go through, because that's similar really across each of the programmes that are offered. And with that in mind, you might want to think about the communities that you work with and support, and think about those different stages and what may act as a potential barrier during that pathway. So screening tests start with an invitation that arrives in the post, and that's something you don't have to ask for. It's an automatic process. So within Public Health Wales, we will get people's details from their GP registration. So according to where you live, your date of birth, that is when you will trigger that invitation that will arrive through the post, whether you're eligible. So that again is sometimes we get asked, do I have to ask to be screened? No, it's automatic, that process. So when you're in that, so that's when you fall in that eligible age range. So when you reach a certain age, or if you have diabetes, that's what will when you will receive that test invitation. So each screening programme will have a different test that is offered, and that may involve going to a location. So the picture on the screen you can see is an X-ray machine used that women would have when they have their breast X-ray mammogram at a breast screening unit. So depending where you live in Wales, and particularly now if you're thinking about your communities, it may depend where you go, how far you may have to travel for that test, and what venue will offer that screening test. So we will use a range of community and health settings for our breast screening mobiles, our AAA abdominal aortic aneurysm screening locations, and diabetic eye screening. Cervical screening generally takes place within a primary care setting or some clinics. And then the test that is different is our bowel screening test kit, as that is carried out as a home test kit. So it's actually sent to individuals to their home address to complete within the home. So that actually removes some of those barriers around travel and access, as it can complete in the privacy of your own home. So that initial test, is just a way of finding out people who may be at higher risk of having the condition that we're looking for. So it won't tell us if you have the condition, just indicates people that may need further investigation. So results are sent. So again, results at another sent generally in the post. So people, and the time will vary in between the different tests people have in terms of how long that result may take to arrive in the post, but generally it's a few weeks following your appointment. Again, so thinking about potential barriers around accessing information, health literacy, whether people can understand the information they receive. And then some people, so most people won't need further tests, but some people will have been picked up as needing further investigation, and those tests will help identify people, or those might be diagnostic tests of finding out people whether or not they have the disease that we're screening for. And again, each screening test will have a different diagnostic test or pathway that they will follow in terms of where people will be invited. They may be into local hospitals, or in breast screening that would actually go to one of our Breast Test Wales screening centres, and we have those based in Swansea for West Wales residents, and we have a centre in Llandudno then for our North Wales. So again, travel may be an issue at that point. And then through that further investigation, some people, it may be that they don't need any further action. The disease we're screening for wasn't found, but they've had to go through quite a worrying time, a period of assessment, and it could be that no further action is required, or it may be that we do pick up a small number of people then who we're screening with the disease that we're screening, and they may require treatment. So within screening, we're responsible up until that point of diagnosis, and then if people are picked up, they are then responsible under secondary care services. So with screening, so that's kind of an overview of the pathway that people will follow through that journey. And it's, we always say it's really important that people make a decision that's right for them in terms of taking part in screening. So we always try and make sure the information we provide is balanced, and it sets out what the benefits are of having those tests, but it also presents any potential risks that may be involved with having tests, or the risk of going for investigations and not having the tests that we're screening for. So it may be that there's a psychological risk as well as a potential physical risk. And there's also that risk, always potential risk, that a condition may be missed through our screening process. So it's important that people remain aware of any changes. So again, it's thinking about, do people need support to make those decisions in terms of making an informed choice? Some people may need information adapted to help them access, the right information for them to make that decision. That's a really, really brief overview in terms of how screening works in Wales. The different programmes. As I said, what I will talk about is training opportunities where you can actually access more detailed information if you feel that this is something you're interested in, and you feel that actually you want to learn more about, to help pass on information to your communities. But the next sort of bit, really, I just wanted to look at screening inequalities, and this data actually is, it looks a little bit out of date. We're waiting on our new updated information to be published. We've had various delays as a result of COVID, but we'll probably be looking at a very similar pattern here. So this is in terms of the number of people who take up our screening offer, and looking at it mapped out against deprivation. So there's a strong link between deprivation and people. So people who are living in our least deprived communities are more likely to take up screening offers than people who live in our most deprived communities. And you can see that pattern certainly across the adult screening programmes, so the bowel, breast, cervical and diabetic. Maternal and child screening programmes, there's very little variation, and I think really because of those tests happening immediately after birth when people are in those healthcare settings, that's generally where those would take place. And it's, again, maybe you might think about some of your communities, they might not necessarily fall into a really deprived community, but you may know that there are issues that people face in terms of accessing services. On our websites, we do have information that's published by cluster level and health board level. So if you did want to find out following this talk more locally what the issues are within your localities, that information can be found on our screening programme websites. So it's just wanted to highlight really that although everyone's offered the same opportunity across Wales, we do see variation in terms of who takes up those tests. You can see that bowel screening on this graph is the programme that has had the greatest challenges, and we can see that in some areas our uptake is very low. We are hoping to see an improvement on that, an improving picture with the bowel screening, as we recently actually updated the screening test that is offered, so it's a simpler and easier test for people to complete, and that has also been reflected then in the number of people who take part. We're seeing more people who are open to actually taking part in screening, which is a positive change. So just a little bit then to cover about the screening engagement team. So that's the team that I work for. So we are a team, we work across Wales. I have colleagues in North Wales, West Wales, I'm actually Cardiff based. But the aim really of our work is to try and help reduce some of those inequality gap. So it's about working with partners, linking in with key stakeholders to engage with communities where our uptakes are lower. So it's about using a targeted approach to try and improve and reduce health inequalities. So it's a really nice opportunity to link into today's meeting, as there could be scope to further support rural communities. We also do a lot of information development and provision, so we work to develop resources around screening. So part of our role, we do a lot of engagement to make sure our resources are accessible and inclusive. So we're always looking for groups who are happy to support and give us feedback on our resources again. So it may be something you might think would be good to get involved with. So we do have screening awareness sessions for people working in, so training sessions available, which I'll talk about now. And again, just wanted to let people know. So if you did feel that you would want to find out more and that you're in a good position to help pass on information to your community, we do have a series of some screening awareness training sessions. So we've recently, they did used to be face-to-face sessions, but we've now adapted our training to be delivered via MS Teams. So again, that's great in terms of people linking in from rural communities to improve that access. And really the aim from that training is to provide people with knowledge and resources around those different screening programmes, so they can take back to the communities they support. So we've got three different modules available. So we've got an introduction to screening, which gives a background to screening and why we have programmes they're offered. Then each screening programme has a session. So we've got a cancer screening programme session which covers breast, bowel and cervical. So it will go into more detail than what I've covered this morning. And then the non-cancer, so that's the diabetic eye screening and the abdominal aortic aneurysm screening. So each session is about an hour in length, so it's not too much time to give up, and you could do all three, or you could just choose one if you have a particular interest. We've got then dates that are scheduled throughout the year, so I'll share those dates with Anna, and she can circulate those to share with you all. So if you did want to book on, that would be great, because it just gives into more detail really, and talks about ways in which you can support your communities. We do also have some Welsh language training sessions that are available as well, so that would be an available session. So just in terms of signposting for further information, so each screening programme has a programme website. We are actually in the process of updating our websites and refreshing them, so hopefully make them a little bit more user friendly. But again, I can share this presentation so you've got the links, and you can then just have a little look at the websites and the information and resources that are available. So each screening programme will have information resources page with a range of leaflets, and then our accessible resources pages, which we're working to develop, but we'll have easy read information, so that's more simple pictorial information that's ideal to use for people who may have a communication barrier, a learning disability. It breaks down that screening information in more simple language, and we're working on our development of British Sign Language information in audio formats as well. Programme reports, so that's the section there where you would find out, if you wanted to find out more about the uptakes of screening programmes in your localities or GP by GP cluster. It's that information there is broken down and available on that section. So as I said, each screening programme will have that information available. Also break down as well and give you more detailed information about the screening programme. So yes, and I think I've just covered about the information available in our accessible formats. So I wanted just really to finish at this point, but obviously just really ask you whether you've got any questions in terms of the communities you support, the programmes. I'm happy to spend the next few minutes answering any questions that you may have. And I've also got our email address for the screening engagement team. So if you wanted to get in touch following today's session with any questions or feedback or booking onto the training, you can get in touch. But really just to open up really to yourselves and see whether you've got any questions that you would like to ask.
Great. Thank you very much, Helen, for that run through. I think Patricia had her hand up. I'm not sure if she meant it to be up or not.
Yes, she did.
Yeah,
thank you for
on.
that. May I ask how you communicate with the visually impaired? Basically, those who can't see. Do you do things in Braille?
Information in Braille can be supplied on request. So if you make contact with the service, each screening programme will have information that they can provide. So it would be a case of letting us know. But yes, that's not a problem at all. We'll be happy to provide that.
Great, thank you for that. Deborah?
Hello, Helen. That was really interesting. As I say, my name's Debbie, and I work with the Community Learning Disability team here in North Powys. And yeah, lots of bits I was scribbling down there. Just out of interest, you know, when the letters are being automatically sent out to individuals, what's the process if there's no response? Is is the responsibility, as in, would maybe the GP then get involved to have a conversation around that, or how does that work?
Yeah, so each screening programme is different in terms of the system that will be followed, but everyone so the time frame may depend in terms of at which stage you would get a reminder letter if you haven't responded to that initial call, that initial invitation. So a reminder letter is sent, and then if no response is then sent at that point, and again, the time variation will depend per programme. The GPs again will be notified. The GPs are notified all through the process if people haven't, non-responder. But at a certain time frame, the GP practice would be notified that individual has been a non-responder, as we call them. And we are doing, in different areas, work around getting GP clusters involved in maybe supporting some of that. We know that GPs can have a key influence in terms of helping to have those conversations with patients. So, but it's dependent on the GP practice really as to what action is taken. And actually, we were saying it about working with people with learning disability. Unfortunately, when we send out screening invitations, the only thing we know about our individuals are their name, their date of birth and their address. So we don't know anything more than, we don't know what their communication need may be. So it may be, like Patricia said, it may be that somebody requires information in Braille. It may be that somebody requires an easy read format to be sent out. So we don't know, unfortunately, at this point, that information. But this is something, the accessibility agenda is something we're really trying to work to improve and make that system of accessing information that's right in that format for people. So it's ongoing work, Deborah, but we're really keen to work towards improving that accessibility and making sure people have access to the information that's right for them. So it's about, again, I think it's that partnership approach. So if we can make sure people who work in key positions like learning disability teams can know where to access our easy read information, it may be additional supports required through partnership working.
Thank you, Helen. That's really interesting because at the moment the government have set aside some money to promote annual health checks.
Yeah.
So we're looking at annual health checks in Powys, and obviously part of those is the screening programs. So some joined up working there. Which
we have made sure that information around screening is included within the annual health check information, as that's that key opportunity to link in and have those conversations.
Yes, yeah, and just from the point of view that when I'm just thinking, because when the letters are sent out, and like you said, that's very minimal information that you have from screening, because then again you've got that around making that choice, because if you've got someone over 18 and parents, and carers are involved, it may be that those decisions are being taken out of their hands, isn't it? And having a bit more information around what that actual screening entails and the benefits. Okay, thank you very much, Helen.
Okay, what I can do as well after help is share some our easy read resources. I can share the link with Anna, and she can maybe share. So just make sure you've all got access to where that information is on the website.
Thank you.
Great. Thanks for that, Helen. Tom.
Good morning, Helen.
Morning.
I represent patients on a number of Welsh and UK committees in healthcare, and I frequently get questions raised about screening policy, and especially that the evidence base comes from the same source for all 4 countries, the UK NSC. But yet we managed to translate them into different policies for access to screening in various areas in the different countries per se. And the fundamental question I get asked is, what is genetically different between a person who lives in Wales and one who lives in England that they should have different screening rules?
You are right in terms of, obviously, you know, it's the UK nations there, so the Welsh National Screening Committee then, you know, takes on board the evidence, and we implement within Wales.
But they reject it frequently, don't they? And they don't take it on board, and that's the point. So what is their reasons for not taking it on board? They don't publish those reasons.
I'm afraid I'm not working at the policy level there, Tom, but I mean, obviously there's nothing fundamentally different, and you know, obviously we will see, for instance, I mean, there's been the recent change to cervical screening policy that's happened in Wales, and that's already been happening in Scotland, but it's not been rolled out as yet in England. So there are variations and differences in what services. I mean, ultimately we do offer all of the same tests, but there are slight variations across the nations.
I know I'm being unfair to you.
Yeah, I'm afraid I'm not at that level.
The point has to be made on the patient's
policy decisions.
But on that point, Helen, I think obviously there are lessons for the engagement team about the changes to the cervical cancer screening, because, you know, there seemed to be a lack of information around why the decision had been taken. Yeah. So has your team taken that on board, or?
Well, it's I mean, it's not just our team. I mean, really, it's the whole of Public Health Wales who manage, you know, in the cervical screening programme, and the communications team involved. And, you know, it's been a big learning curve, I think, for the whole of screening, really, in terms of how changes are communicated and making sure information is presented as clearly and as accessible as possible, and I think there's a lot of learning from what has recently happened. Cervical screening changes have been made due to advancements in screening, and that's been a positive change, but obviously there was a misunderstanding or lack of understanding from the information we put out in terms of how people understood why that change was happening. So I think, yeah, so ongoing learning, and just highlights the importance of engagements in terms of getting our messaging right for communities and people.
Yeah, I from my understanding, having been harangued by various people, it was about a dearth of information rather than a misunderstanding of the information that was there. So if you had put the information out, it obviously wasn't on places where people were seeing it, I think was the main lesson I had. If you felt you were putting the information, it obviously wasn't on the right platforms.
Okay.
But that's just, you know, I appreciate that you are not in a position to answer all the questions about cervical screening at all. Anna, did you have your hand up?
I did. I just had two questions for you, Helen. Sorry. First was, you mentioned inequalities and you referred to deprived areas. I just wondered, did you know rural inequalities in terms of, is the uptake of screening tests in rural areas lower than urban areas? Based on, you said you've got it per health board, has anybody done an analysis of that?
Yeah, so so within we break up the uptake is broken down by cluster, so that data is available. Actually, within cervical screening, I think actually within Hywel Dda there are actually sort of low uptake areas within that programme, but I don't know the refined data around you know, rurality, but you know, it's certainly available, the cluster information, and I think, you know, I think probably access and travel can certainly maybe pose, you know, potential barrier as well to certain tests.
Yeah, so I'll have a better look at that then, and maybe do a bit of analysis based on the health board areas. But following on from that and the earlier presentation we had today, and also a conversation I had to you about the bowel screening that was going on in some of the farmers' marts, I just wondered what are the outreach services that might be available in rural areas from a screening programme perspective? I know we've got the breast screening, cervical screening is very much primary care based.
Yeah.
Then the bowel cancer screening, is there an outreach element to that?
Well, I think that's where we really need to link in with key partners, and having information available in key settings where people are likely to access, so within the communities. And I think that's why it would be great to promote, that's why joint working is so important, to have people within the community and working with rural communities, like you said, the farmers markets or Farmers Union Wales. If we can get the right key organisations involved in helping to raise awareness and signpost people or share information on their social media or information points, that's kind of our best way of cascading that information. Obviously, all GP practices across Wales and pharmacies and certain information points will always be sent information around screening. We obviously don't know necessarily whether everyone puts that information up and or shares that information, but we do have a range of resources. We have also we've just developed some updated editorials. So again, that's sort of if you've got community newsletters or bulletins that you send out, we have got some information around, written information around screening that you can share. So we've got we're trying to build on the range of resources really that we can share with partners.
Yeah, so maybe that's something that we could work with you moving forward.
Yes, yeah, absolutely.
All right, thank you.
I think also, Anna, that needs to be, which you probably are doing already, Helen, is combining with the work they're doing on developing the NHS app. I don't know if you're involved with them, but it seems to me that might be, if it's developed as they're talking about, a platform that might be very useful for you.
Okay, that would be great to get further information around that.
At this point, I always say talk to Anna, and she coaches me after the meeting.
No, that's fine. I'll send you details, Helen.
Yeah, that'd be lovely.
There's another question in the chat box, which was who chooses where the invites get sent to for screening? I think that's probably a typo, because you covered who chooses who gets invited. It's probably where she means where the invitees get sent to, if you see what I mean.
Yeah,
so who chooses where people are sent to for their screening?
So it's all based on location. I mean, we try and make services as accessible as possible. There have been increasing number of challenges as a result of COVID in terms of access to venues. So our diabetic eye screening and our AAA screening programme have had real challenges in terms of finding access to locations. So there have been some changes as a result of COVID, but it's a case of programmes working with local partners to agree screening venues. But I mean, we do try and there are certain things that obviously always need to be available services. So it's on a service delivery point of view and working with local partners to agree those venues. So that's individual screening programmes. Obviously, we try and make those services as accessible as possible, but we appreciate some people will have further distances to travel than others.
Yeah, I mean, depending on where it's being organised from, people have different interpretations of accessibility. But do people get presented with options of where they can turn up sometimes or not? Is it always?
I mean, I think if people have missed an opportunity or if they said they couldn't get to it, I think there could be flexibility. That would be down to contacting the service and having that discussion. Right. So there's always I'd say if somebody's got an issue with access, contact the service and discuss whether there's a more convenient, suitable location to access. It's generally done, how it's done is done by sort of GP registration. So for instance, if your GP's we're invited with breast screening an area, it would be done where your surgery is registered. It would depend in terms of where you're called for screening. But again, if that venue is really inaccessible to you, it'd be a case of contacting the service and to discuss whether there was somewhere else. I mean, I can't say that for certain there would be, but it may be that there could be another option available.
Yeah, fine, but that depends on the person sent the invite to be proactive.
Yes.
In that case. Yeah. Right. So that's a bit of information that needs to get out there, that it's it's not a fait accompli where they've been or when they've been sent, but they need to do something about it themselves.
Yeah, I mean, I think if there's a barrier, it would be a case of letting us know, contact the service. Yeah, then that would be really for the individual service to see whether there would be somewhere else that's more accessible. And it's also thinking about the time frame, so people are called based on when they are due for that screening appointment. So it's also thinking about that as well.
Great, thanks, Helen. Tom and Deborah, are they new hands or old hands?
A new one from me, if I may, Jack.
Yeah.
Old from me.
Yes, Helen, the comments you made about statistics at cluster level are very, very interesting, and I wondered if there's any way in which we can get access to them. I mean, with social media these days, I mean, most communities have their own sort of residents and locality groups, as it were, and I've used quite a number of those for health promotional sort of purposes. National figures tend to be overlooked and not responded to terribly positively, but when you bring it home to roost, as it were, with a local sort of figures, then there's much more cutting in their effect. So I wondered if it's possible to access these figures too.
Yeah, the reports are available on the websites on the so they're under the heading programme reports. And that's where the statistical data for each screening programme is available.
Terrific, thank you very much.
Okay. And also as well, on the note of social media, we're about to send out some new sort of set of infographics that can be shared via social media platforms that are just trying to get out some screening messages. So again, I'll link in with Anna, and as soon as they're available, share those, and they can be sent and cascaded so you can put some messages out on your social media pages.
Great, thank you.
Thanks, Tom. I sent some other work heading Anna's way here. Yeah, just to comment on social media and websites. I think most people are accessing their information through social media rather than websites nowadays. So websites are a sort of dying breed, it seems to me. So to make your information accessible, it's got to be out there on extraordinary platforms that I know nothing about. Great. So I think that's all the questions I can see. Anybody left with a question for Helen? Great. Helen, if we may share your contact details with people.
Yeah,
so
absolutely.
So people can contact you, or indeed you can contact other people if you need to get some help in getting messages out.
Yeah, it's best maybe if you use if I share the presentation, the screening engagement email address would be the best email, and that can be fielded within the team. So that would be great. Yeah,
that's great. So once again, I hand all that detail over to Anna. And I'd just like to thank everyone very much for attending. And before we go, if we could do the Mentimeter thing again, Anna, can I hand to you? And apologies, everyone, I've had to turn my camera off, but my broadband wasn't coping.
But we've got a lot of people who've already been on voting, so I'll put the address in case you haven't, if you don't remember, or there's new people join. So if everybody can go to Menti, I'll share the screen now, and if you can click on, can't see if I can find it, click on the, there we go. I'm use the code 26956493, and if you can just take a vote, and we can see the scores coming up. If you thought the presentation was interesting, was it relevant to you personally or to your work, and you feel that you're better informed. Well, the good news is that just about everybody feels much better informed, Helen. So you've done a very good job of engagement today.
Helen, you don't have to watch this slow torture if you don't want to. Great. how long do we need to leave it up, Anna?
That's fine. I've got the address there, so everybody just makes a note of the address and the code, and then you can keep voting. I'll just come off this now. So
Right.
yeah, I'll stop sharing.
I'll try turning my camera on to say thank you and goodbye.
Sorry,
to
Anna,
everyone.
what was the number again?
It was 269. I'll type it in the chat box.
Thank you.
269 56 493.
Thank you.
I'll put it in the chat box.
Great. Well, I think now it just falls to me to thank everybody for attending. It was very nice to see so many people and so much feedback and questions to the presenters. In this strange world we live in, we're all getting a bit webinared out, I think, but these still seem to have a very constructive part to play. So thank you one and all. Thank you again to Helen for her presentation, and I shall say goodbye and have a good rest of the day. Thank you one and all. Diolch.
Thank
Thank
you.
Bye.
Thank you. Goodbye.
Bye.